Let me turn over the floor to you all and just see what's on your minds.
Can I answer that person's question? Let me start by answering that person's question about if there were two electronic prescriptions generated and transmitted for a single patient, that would be one electronic prescribing event, because it's at least one prescription was generated and transmitted electronically, is what you are reporting.
Okay, so just a little logistics. What we're going to do here is we're going to try to keep on time. We're going to do 10 minutes of questions for CMS. Then we're going to take a 5-minute break after that for the panelists to come up. Martin here has the microphone, and he will walk it around to whoever has the highest hand in the air.
Okay, I got the microphone on first here.
Okay, here's my question. Would you review the penalties for not doing this again? You alluded to the electronic prescribing being 1% less of reimbursement. Is that forevermore, or what's the duration on that? And then what would be the penalty for not doing the electronic health record?
For the electronic prescribing, the 1% payment adjustment that would be applied for 2012, there's also a requirement such that you could, if you were not able to meet this by June 30th and you were subject to the
Penalty.
To the penalty in 2012, there is another opportunity to get started after June 30th, and then that is going to work towards the 2013.
And if you chose never to do it, what would be the penalty going forward?
Eventually, the penalty going forward is going to wrap up into the EHR incentive program. And I apologize in my haste to get through all those points. I did neglect to say that beginning in 2015, or if you are not a successful EHR, if you do not successfully demonstrate meaningful use of an electronic health record, everything's a mouthful, I'm sorry. But if you're not successful with EHR by 2015, there will be a reduction in your Medicare physician fee schedule allowance of 1%. Okay? And I know that that's going to increase in 2016 and 17. I believe the e-prescribing penalty sunsets in 2014, but then the EHR penalty reduction in payment picks up from there. So if you're never a successful electronic prescriber and not successfully demonstrating meaningful use of EHRs, then one reduction in payment is going to flow into the next. And I believe the law talks about 2015, 16, and 17, taking it all the way to 3%. And I believe there's some secretarial discretion perhaps after that date. So I can speak for the short term. I'm sure there'll be a lot more information about who might be exempted from that due to circumstances such as lacking infrastructure to successfully use electronic health records and that sort of thing. There's secretarial discretion in the law for that currently, and before we get to 2015, you can be sure there will be further implementing instructions on that aspect of it.
What's the extent of shared data that you're looking at? For instance, there are probably 3 big systems in the metropolitan area: St. Luke's, HCA, Carondelet, and that's not trying to dismiss other facilities. They all have different systems. I'm an HCA. You can better well believe I ain't going to get into St. Luke's. Our patients don't identify with a system, and they may go to several different places to get care. So I'm going to be penalized because I can't get to somebody else's records. You know, I mean, that's what shared data is, isn't it?
Well, that's one aspect of shared data. It's certainly.
But that is important.
Interoperability of systems is definitely one of the goals of this.
So if somebody has their mammogram at an institute that I'm not a part of, I need to be able to get that, because you certainly don't want me to order another one when she's already had one.
Right,
You know,
and
that's a simple.
That's why that's the importance of like health information exchanges.
I mean, to what extent are you making it so that all of these are truly going to be interchangeable?
Well, I think what we're going to see from stage one, and if you look at those, if you look at the individual specification sheets, when they talk about transmitting a prescription electronically and what is successfully meeting that, you know, we're talking about percentage of things. I have to say, I do not have in the front of my head right now all those different criteria, but it starts slowly in stage one, but clearly we expect to build on that in stage two and stage three in terms of data sharing. So I don't have a really...
They don't share now.
I understand that. And I don't think there's really anything in stage one of meaningful use that requires that.
It requires a test.
That you test, yes.
Test and then one test.
That's right, thank you.
Test and only a test. Right.
Yes,
It doesn't have to be successful, just one
yeah.
test.
So what's the test amount?
Trying to exchange data on at least one patient
Yeah.
with somebody else. Electronic.
So if they copy their electronic record and send it to the individual, that doesn't count.
That does not count.
That's the caveat with that, is you have to make sure you're testing with somebody that can potentially receive it.
But that's the purpose of my question, you know? There are multiple different systems in this metropolitan area, and they're damn well not gonna talk to each other.
On the campus side, campus health information network, with the organizations that have in the state, they're gonna have a structure in place for you to test that, actually have a place to send the information and to the requirement for the test, so that.
But this is metropolitan, this isn't just Kansas, and this isn't just Missouri.
Right, I'm talking about satisfying that stage one measure, that infrastructure will be in place before you do that.
I just so happen to have the specification sheet for for capability, your system must have capability to exchange key clinical information, for example, problem lists, medication lists, so on and so forth, among providers of care and patient authorized entities electronically. The measure performed at least one test of certified EHR technology's capacity to electronically exchange key clinical information. Okay, now, it has to be to a separate legal entity, and let's see. Each instance of certified EHR technology must be able to be certified and operate independently from all the others in order to be distinct. The exchange of information requires that the eligible professional must use the standards of certified EHR technology as specified by the Office of the National Coordinator. Anyway, I would say get this sheet from the website, from the meaningful use page, and I'd be happy to discuss it with you further if you have any other questions that need clarification. Okay? And you can get to me through that regional email. There is a long way to go. There definitely is a long way to go. It's a continuum, certainly. And, you know, like I said, the regulation and where we are right now, we're at stage one. We fully expect that we will be building on that and seeing us raising the bar.
We're not even stage one, there are less than 50% of your physicians have API-MRs in the metropolitan area.
Your point is well taken.
Let's take the next
I have a question about these incentives and then the penalty or whatever you want to say. We're moving ahead. We have a meaningful use certified EHR. We could certify today if we wanted to, but we're a qualified health clinic and there's some state things going on that we're waiting probably until 2012. But you say we're going to have a penalty for our Medicaid patients even though we're using all the technology.
Well, I'm sorry, time out, I'm sorry. Medicare, that's Medicare only.
Yes,
That
but we also
1%.
have about 15 to 18% of our patients are coming from Medicare.
Okay. You have dual eligible patients. You're participating in the Medicaid incentive program.
Yes.
But if you weren't a meaningful
What I'm saying-
user,
So we're using certified ERX technology.
ERX, okay, you're talking about
I'm
just,
saying, but you're saying if we don't somehow certify that
sorry.
we're using it, we're going to get a penalty next year, even though we're using it.
wait, we're talking about the e-prescribing?
Yes.
Okay, and that is strictly a Medicare
Yes.
initiative.
Please begin reporting, if you're using e-prescribing, please begin reporting that, at least 10 events that you've.
Yeah, but it's a lot of paperwork. We're already busy working on meaningful use and primary care medical home things. But,
In order to.
so we're going to do everything right and be ready ahead of the curve, but you're going to penalize us.
In order to avoid the penalty, it would be at least 10 e-prescribing events reported on claims by June 30th.
That's not paperwork.
That, no, it's adding a code to your,
That's true.
to your,
Code is G8553.
Is that the one for being
yes, I think it
excluded?
is.
Yeah.
No, that's the